Good afternoon. We wondered if we would have anyone after lunch on a beautiful sunny day, so thank you for jumping in the room and out of the sunshine. Happy to be with you this afternoon. My name is Briana Duffy. I serve as the market president for Carelon Behavioral Health. I am joined here today by my colleague, Brad Lerner.
Hi, everybody. I'm Brad Lerner. I am the Health Policy Director for Mental Health and Substance Use Disorders at Elevance Health, which is the parent company for Carelon Behavioral Health. And both of these companies have been rebranded, so you may recognize our former names of Anthem and Beacon, for those of you who aren't familiar with the new company's names.
We're not supposed to use those words a whole lot, so we're just going to breeze past that now, talk about our new state of being. I'm going to talk a little bit this afternoon, and as I look around, there's a lot of colleagues that we know and know well. So we're going to let you play Stump the Presenter towards the end of our dialogue today in the hopes that this is really an interactive discussion. I'm going to kick us off by talking a little bit about the way in which Carelon Behavioral Health is thinking about the world of integrated health. And to talk about the world of integrated health is really an exciting opportunity. And I say that because as a person who's been in this industry for more than a minute or two, I will say that I spent the beginning part of my career trying to convince a lot of the folks that were in either medical professions, health plans, or policymakers about why behavioral health mattered and why they should care about it. The good news is I'm pretty awestruck by the fact that we don't have to make that argument anymore. The recognition of the role that behavioral health plays as part of total health and well-being is so fully appreciated. So under the careful what you wish for, now we need to make good sense of how this all comes together, and that's why we're going to have an interactive discussion this afternoon. At Carelon, we used to talk about, a bit when we were Beacon and before that, but at Carelon, when we talk about the world of integrated health, we really think about treating the whole person, which is the most obvious way to talk about what integrated health is. How you deliver integrated health might be a little bit more complicated, but the concept of treating the head being attached to the body is certainly not something that's new. So one of the things I'm going to talk to you about 6 sort of principles that we organize around at Carelon Behavioral Health. The first is that whole person care is the only way forward, period. So there really is no other possible scenario. And it's interesting, I have a lot of friends and family that are interested in talking about behavioral health in a way that as a younger person, we just didn't have the same level of openness. And I've got a lot of friends and family that are into fitness and making sure that they're looking good and that they are thinking about staying, topical of what's happening in politics, and they really think of themselves as being really well-rounded people, but the antidepressant they took maybe didn't work quite as well as they'd hoped it would, and so they're feeling perhaps a little bit more depressed than their external presence really will allow them to reflect. And, we have these dialogues, which is to say, when we talk about being healthy, you got to get that feeling better too, or you're really not completely healthy as a whole person. So it's exciting for me to be thinking about the notion of whole health. So whole health is the only way forward. The next thing that I will say is that person-centered care and quality of life are intrinsically linked. So if we're going to define the ways in which we have folks get into whether it's support or official care, and I'm drawing those two things as distinct differences, it's really important that we're thinking about devising ways in which are going to work for that person. You know this, we know this, but that's one of our core principles. We also know the consequences of not addressing behavioral health, and those are some frightening statistics. That could be the rates of increased suicide, that could be increasing rates of unhealthy relationships with substances. That could be the fact that 29% of folks receiving long-term Social Security disability are receiving that because they have some type of a behavioral health need. I think that's a really big number, and it doesn't really bode well for this notion of recovery. If we believe that folks can get better and feel better, I'm going to argue that we shouldn't have 29 folks spending their current existence on long-term disability because they don't know how to grapple with their behavioral health condition. Fourth thing that I would say is everyone has a right to be just and have equal access to being healthy. And so what does that look like? That really starts to be thinking about the use of analytics, technology, identifying people earlier, talking about prevention. The fifth that I would argue for you is that ultimately technology has a huge role in all of this. So whether that's an app, whether that's a different type of technology, it's really the analytic and the insights that help surround a lot of this that also become really critical. So those are 5 things that as we think about designing supports, programs, the ways that we think about the world, those are sort of some of the things that we orient around. The last thing that I would say is that we are excited to be having this dialogue with you. The other thing that we know is that it's all about collaborative partnerships and thinking about as new and different solutions are coming together on the market, that we are thinking together about how to make sure that we're driving that belief in recovery and that people are feeling better. So Brad, you spend a lot of time thinking about how we can make sure on a public policy perspective we are out there and we are doing the best that we can. You want to talk a little bit about some of the ways that we're using technology, data, analytics?
Yeah. Thank you. And thanks again for being here. And Briana, that was a great overview of sort of the large umbrella issues and framing, really, of what Carelon Behavioral Health is looking at. For the last couple of years, I think it's no surprise to anybody that integration is a top issue with policymakers. So in my particular role at Elevance Health, I've sort of had the front row seat at really looking at what the best policies are to help proliferate integrated care, but also sort of internally being sort of the surveyor of Elevance Health's approach to these issues. Elevance Health is a health plan in many states, but we also are in all lines of business. We do commercial business, we do employer business, we do Medicaid managed care, we do Medicare Advantage, national accounts. So we've really got a front row seat to sort of look at the programmatic landscape in this area. And then the second issue that, from a policymaker perspective, is the collaborative care model. And I believe there are going to be several presentations throughout the next day or so talking about that. In fact, Meryl and I just came from a luncheon from the Meadows Institute where that was the topic. And there's not only federal legislation, there's a lot of activity in the states to try and get Medicaid plans to proliferate collaborative care. And we're sort of looking at this like we believe this model is a great model, but I've worked with several of our psychiatrists sitting in the front row here to cheer me on about, well, why hasn't this taken off the way we think conceptually it should? And what are the things that we're going to do as a health plan and as a leading healthcare company to help move this forward? But going back to the part about the surveying, so even going back to the Senate Finance Committee from about 2 years ago, they sent out requests for information to understand better what are integrated care programs that work, don't work. And so, like I said, I began surveying them. And one of the things that at Elevance Health and Carelon Behavioral Health that we've really leaned into, and I think it'll resonate with a lot of the folks in this audience, is sort of the predictive analytics and really understanding if there's a way that we can find the members who are demonstrating behaviors or have comorbidities and be able to intensely reach out, kind of grab these members, help them on the front end, and sort of then steer where their care will go as opposed to being on the back end and reacting when things are already acute. And we've had several programs in particular that I thought were pretty interesting as I was doing my research internally that were more focused on certain diseases. So one that came to mind was we had a cardiac rehab and chronic pain program. Again, using predictive analytics to bring in the behavioral health case managers, because as you know, people who are in those, have those conditions definitely would be subject to mental health issues. And being able to sort of tie that on the early side may help present a spiraling there. We also have a predictive analytic program related to sleep apnea. As I'm sure many of you know, I was up like in the middle of the night last night, just trying to figure out how to curb the behaviors there that those comorbidities there. We also have a program with dealing with health wellness that has both nutrition, food scarcity, abuse, again, sort of taking the claims, taking the analytics, being able to get to those members. But one of the bigger programs, and I know, Briana, you've had a long history with this, is our Massachusetts Child Psychiatry Access Program. This one isn't one that uses the predictive analytics, but this is probably, I think, the jewel of an integrated care model. This, obviously, as you all know, that there is a shortage of child psychiatrists. There has been for many years. It's particularly acute now. And what we did in Massachusetts, and Beacon was the first company to sort of do this, was to be able to find a way to do those consultations with the primary care and the pediatricians and be able to take a small resource and be able to expand the time that these psychiatrists will be able to meet the maximum patients. And so, Brianna, I know this program's been expanded. I was just talking to you before. Do you have a little bit more on the different kinds of psychiatry access programs that we've been promoting?
Sure, and thanks, Brad. The Psychiatry Access Program, and many of you in the room are well versed in this, but I will just say it's really working with a discrete number of primary care sites. And so the goal is that you provide support and some practice site transformation in helping primary care sites begin to identify individuals who have a need in behavioral health and for whom the primary care physician does not feel comfortable addressing that need. So this is individuals who are complex, there's something different about what's going on, and primary care is kind of feeling like they need to raise their hand and get a specialty consultation. And in the recognition, as Brad was talking about, in both delivering integrated care, but also recognizing the scarcity of resource that's there, what happens is the practice site transformation coordinator works along with a hub of psychiatrists, and this hub of psychiatrists is available for consultation to primary care. Oftentimes that means there's either a direct consultation to the doctor themselves, or there's actually a visit or two for the individual who's presented in front of primary care pediatricians to go have a specialty consultation. And then the psychiatrist has a conversation with the primary care to say, hey, this is what I think, this is what things are looking like. Either there's indication for medication, and here's the medication, why I think this would be the right choice. Or I don't think the right answer is medication, but I think X, Y, and Z is there. So the hub of the consultation program actually includes not only the psychiatrist and the practice transformation coordinator, but there's a social worker, there's a peer, there's community health workers who are really specialists in understanding a lot of the social supports in that local community. And what we have found over the years, and really starting with our child psychiatry program, is that when you've got your hub of psychiatrists and you've got your spokes of primary care practices, over time, what you're doing is you're really helping to increase the competency of the primary care provider and their own comfort level in addressing some of the behavioral health conditions that they see. So, okay, the last time I saw this condition, this is what we talked about doing, and now I feel like I've got more knowledge in this area. So over time, you see the use of the consultation actually go down, not because people lose interest, but actually the understanding and the skill set of the primary care doctor increases, and over time you can add a new hub to that same spoke. So it's a really wonderful service in that you can use the same psychiatry hub over and over and over again to get good sort of support and leverage. And I think the psychiatry programs have been really happy to be part of that hub and helping to provide that level of expertise. So to your original question that has taken me a while to answer, anyone in the room knows I'm capable of that. We have specialty in both child psychiatry and addictionology. So we've got a mixed STAT program, which is substance abuse treatment. And then we've got a perinatal program focusing on moms and new parents, focusing really mostly on postpartum depression and concerns in that front. So those are the three primary programs. We are working right now to actually start a consultation program for individuals that have a co-occurring, not only behavioral health disorder, but an intellectual disability disorder. So that's a little preview of things to come. But I think what we're really talking about is how we can create additional access beyond what's there. As we know, the good news is that behavioral health is on the forefront of everyone's conversation, but what we also know is that we've got a supply and demand sort of inequality out there, and it's really challenging to get folks connected to care. And at Carelon Behavioral Health, why we feel it's really important to get individuals connected to needed care, getting folks connected to good quality needed care is actually even better, in case folks were wondering about that. And that's where the partnerships with so many of you in the room really come into play. We feel as though over time, we're going to have increased analytic insight into who may need what, and then the question becomes, and so who's going to supply that level of support? And we're really excited to be thinking about how we create specialty pathways, general pathways, and other types of resources that we can address with the help of all of you.
I mean, I think that, what's interesting is there's sort of the 1.0 integration and the 2.0 integration. This MCPAP model predated the pandemic, and it really predated some of the incredible technology advancements we've all seen through the pandemic. And so now you think about how, that model was so successful. A similar one on the SUD side, Project Echo, which I know many of you are familiar. If you're not familiar with it, it's essentially a hub and spoke model where you train individuals for substance use disorder consultations to help providers who don't have as much experience or could learn from one another to a sort of a collaborative. And we've had much success with that over the years. So I'm thinking that, with the creative minds that are here at this event now, how much these models that have already been proven to be successful can be sort of maybe even taken to the next level, and further resources could be even more realized, like you're talking about in terms of the workforce shortage. I do want to get back to the collaborative care model. Some of the concerns that we have heard, the model is definitely based on the primary care practice doing the billing. They're the ones who are responsible for the reimbursement. And so as the behavioral health leads looking into this, we're trying to figure out, what is our role here to incentivize and make sure things are going to work. And so these involve using case managers, psychiatrists, or nurse practitioners of a certain level, and we will be able to sort of, embed the behavioral health providers there, and hopefully this model will take off. And what we've learned is that, not all the primary care practices are willing, some of the smaller practices are financially struggling to figure out how this will work. One of the suggestions that we had put in, and Dr. Mahmood had actually suggested this, is maybe unbundling the case management piece of this to maybe allow some more flexibilities. We could also maybe allow different licensure types to maybe expand within the model. So we're trying to creatively push forward. Senator Cortez Masto has a bill currently related to collaborative care and incentivizing and putting more money into this model. But we also want to make sure that we fix the model to get the take-up that we're looking for. So maybe in our Q&A, if folks have some ideas there or some of the things, some of the gaps that they're seeing, part of my role at Elevance Health is to relay these to the regulators and policymakers. So I think we all agree that this is a model that is kind of a gold standard for integrated care, but there is a gap then in full realization right now in terms of why we're not seeing the take-up that we think the promise of this model has been. I recognize that not every state on the Medicaid side is reimbursing for collaborative care codes, but I think we're getting pretty close. I think the last I checked, it was definitely over 30. So we continue to, obviously want to make sure that that proliferates. But in terms of, just the ideas and the technology that's embedded in this room, I think we have a lot of opportunities in that space there. So, Briana, another question for you that I would have is, in terms of integrated care, do you see the some of the programs that I was mentioning? Are there other ideas that you all at Carelon Behavioral Health, do you spend time sort of coming up with the ideas? Or are you waiting for folks to kind of bring them to you? Or how do you guys evaluate what will be the right decision for you to put sort of your chips on?
That's the question, right? The answer is both. And so, yes, we certainly spend some time thinking about what strategy we feel is going to be effective. I think inherent within that is really, again, our topic is integrated care and whole person care. One of the advantages that we feel we really have is that as a health plan and as a health partner, we can see medical data, we can see pharmacy data, we can see behavioral health data. And so as we're thinking about where and how we might look to have better integration occur, using the example that you just gave, Brad, about collaborative care, we can kind of identify by site location of primary care whether or not they're billing for any sort of collaborative care. And if we don't see that there is high use of collaborative care, and we know that it's an area in the country, in a state, where there's some provider deserts, I know those are not popular terms, but we all know that those are the realities. This allows us to be a little bit more proactive and go identify primary care practices who maybe are ripe for a conversation about starting the use of collaborative care. It allows us to look at where we're seeing that there's low volume collaborative care codes being billed and think about how we can be a little bit more specific. So that's a bit of what we're doing to think about how we can offer stronger and more integrated care. But then again, it really comes to a lot of the resources that are available in this room from the services that you're offering. The other thing that we're really thinking about is really not waiting for behavioral health to be at a level where people are feeling distressed. We know that prevention and early intervention really make a difference. And so the goal for us is to not necessarily play the goal of a catcher's mitt, meaning we're going to catch it when we see it. We know that it's there, but if the ball doesn't have to get thrown in the first place, now isn't that really what we're trying to accomplish? So we're also trying to think about how we can be thinking differently about youth and specifically about pediatric practices, and how we can be wrapping not only around pediatric practices, but schools and local communities, and using technology. And so I think we're really open to some of the resources that we know are here today and at the conference about how we can be interacting at that level before we even know that there's a behavioral health need. But instead, we know that there is just a need for education and for training, and we don't want people, we were having a conversation this morning, getting bad advice on the internet because of, you can Google just about anything and get all sorts of answers. Some are helpful, some are not. So we want to make sure that people are also getting the right answers.
Well, so you just all got your price of admissions, because you got some good insider information here from Briana on the thought plan. So in the last few minutes before we take questions, I did want to bring up one topic that has been taking up most of my time for this year, and will continue to, is mental health parity. And obviously the concept behind mental health parity is at the core of integrated care, which is really that mental health and physical health and whole health care are all one and the same. There is no health care without mental health care. That's how I start all my comments, by the way. That these are no longer sort of other, as Patrick Kennedy would want to say. But I believe that, we're in an area though right now too where, the pendulum swings in different directions, and I've seen a lot of discussions about what types of mental health criteria that payers use, or different tools that payers use for behavioral health, and this idea that they have to be exactly the same as what is being used on the physical health side. And I think that that's really where we have been having some struggles, because we're always trying to make sure that the lodestar of our integrated care approach is quality, 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 and then obviously access, and of course affordability. So, we want to make sure that when we're trying to align these physical health sort of constructs and paradigms, applying them to the mental health and substance use disorder side, while the concept of parity is something we strongly believe in, there are still differences that we are trying to work through in terms of the constructs of the expectations of that law to be realized. So I think that that's really important as we even talk about integrated care, because there is really the top issue within policymakers is trying to ensure compliance with parity. It's of utmost import to, I know, to us as Elevance Health, Carelon Behavioral Health as a provider company of services, and then really the whole payer community. And I think that, I think it's definitely a cornerstone, like I said, of the mind body, but we're still working through there because we want to ensure that the policies that realize parity really, promote quality, promote access, and promote affordability. And, I don't think we're quite there yet, but it's not certainly from lack of attention and trying. So this will be a topic that I think will, for those of you who go to many mental health conferences, this will be one that will probably be of top of mind for the next, next near future. So I look forward to working on that. So do you think, Briana, we could open it up in our last 5 minutes here to our esteemed colleagues?
I ask that you ask really tough questions to Brad and easy ones to me.
Good afternoon.
Hi.
This might not be a really tough
Can you introduce
question.
yourself first?
Yes, I will. I'm Robin Trush. I'm with HMA Consulting. And my new favorite bumper sticker to wear this latter part of my career is maternal child health is the best form of prevention, right? So whether you're speaking to the trauma-informed care that you could surround that with, or just integrating the EPSDT program with maternal child health, I'm curious whether you want to talk about it from the Elevance perspective or particularly the Carelon, where you're at with that concept, and in particular, the work around the EPSDT program as well. And now that we have maternal child health up to 18 months postpartum for Medicaid recipients, hallelujah.
That's great. We actually have a couple of our esteemed colleagues in the audience. Would either of you like to talk about our maternal health program?
We have a special guest star. I love it.
Yeah, my name is Hussam Mahmoud. I'm the Regional Chief Medical Officer for the eastern part of the country for Carelon Behavioral Health. I have the pleasure of working with these folks. So our maternal health programs are, I find them very fascinating because the jumping off point is a substance use or behavioral health condition. However, the program itself is actually a whole health program that incorporates everything from prevention, discussions about contraception, about prenatal care, in addition, of course, to substance use disorder treatment, as well as prevention when appropriate. The program is kind of in line with something that you said, Briana, utilizes data analytics and predictive modeling in order to proactively identify folks who are not necessarily struggling with these conditions, but are likely to struggle with these conditions, and proactively reach out to them in order to engage them in conversations about both maternal health as well as behavioral health conditions. So it's an integrated whole health program that where the jumping off point is behavioral health. The other thing that I really like about the programs that we have is the fact that we use non-clinicians in addition to care managers who are clinicians in order to engage folks in treatment. And we utilize a combination of in-person, telephonic, as well as digital outreach in order to keep them engaged, to ensure that, you know, there are different approaches to keep folks engaged with our programs.
You can ask the really tough questions to the doctors. Thanks, Dr.
Hi, thanks for being here. My name is Christina LaMontagne. I'm the CEO of Clarity Pediatrics. We have contracts with both of you, actually. And what we do is we work with pediatricians and health systems to integrate behavioral health diagnosis and group virtual treatment for children with ADHD, which impacts 10% of kids. It can often be the tip of the iceberg for other behavioral health conditions. Because we do integrate with pediatricians and health systems, I'd love your advice on best practices, lessons learned with MPAP and others for how to drive awareness and, you know, regular utilization from very busy GPs and pediatricians who have lots of options. How have you found it is best to bring these integrated programs to top of mind so they get utilization and kids get better?
It's a great question, and I think what we have found over the years is if you were to sit down with a group of clinicians and discuss whether or not integrated health was the right path forward, you don't get any pushback. There's zero contest. How you actually make it happen, again, is where it gets complicated. I described a little bit about our practice model around MCPAP, where we have a practice site coordinator. A piece of what happens with that practice site coordination is when they've identified pediatric practices that they're going to work with, they actually go and they observe a day in the life of the pediatric practice, and they see how they actually move patients through the office. And it sounds so simple, and I'm looking around the room for some of my colleagues that have done this work with us over the years. It sounds really simple, but it's not. And the less disruptive you can make some of that referral process occur, the more likelihood, the greater the likelihood that you actually see a stronger adoption. Meaning if you say, hey, you're gonna completely revamp the process that you use when you bring a patient in from the front desk into the waiting room or into the exam room, and then you want someone to suddenly go from one exam room to another exam room, it's probably not going to work. You need to figure out how to get someone in the exam room to help make that facilitation for the consultation. So again, when we talk about practice site transformation, we're really not talking about clinical reform and the practice steps that we're taking, but we're really talking about how you change some of those implementation pathways. So I don't know if that's particularly helpful, but that's been one of our, oh, and we have another doctor guest. So here we go, Dr. P.
Another special guest star.
So I'm Jim Polo. I'm the Chief Medical Officer at Carelon Behavioral Health. I happen to be a child psychiatrist and a member of the American Academy of Pediatrics. The reason why this is such a great question is if you really think about it from a behavioral health perspective, getting upstream to really improve the health of large populations means you have to go downstream as young as possible. So pediatricians have the enviable position of being able to see their patients on a regular basis when they're very young. And it's been my experience that the more that you can support them in their practice to do their job in vivo in their clinic, the more likely you're going to improve the outcomes of their kids, both from a physical perspective as well as from a behavioral health perspective. So the collaborative care model, while it brings in that expertise in the adult practices, doesn't have the same amount of evidence in child practices, not because the evidence isn't really kind of going to be proven to be shown, but we haven't actually done the studies yet. But the reason why that's significant is because when you go into pediatric practices, you will find that the percentage of kids that actually need behavioral health and get it is far lower than it is in the adult population for a variety of reasons that most of you probably are aware of. So it's been my experience that helping the pediatricians to really understand what they're looking for, giving them the practical advices in the moment, because remember, they see kids at a very rapid pace, just like we do in our adult practices, to do what Briana was referring to earlier, is help raise their ability to be able to understand how to actually learn how to do a better job of addressing those behavioral health conditions, identifying the ones that are significant early that they can't and should not treat, and referring those ones out to the appropriate place.
Thanks, Dr. P. And we now, in front of us, have a negative time. So that means that we're over. So thank you very much. Happy to take any questions after we wrap up today. Thank you.